Okay, today we're going to discuss about the adverse effect of the blood transfusion. So this topic we'll discuss here about the ill effects of our blood transfusion. So we're talking about problem related to the risk of your blood transfusion, which is the negative side of your blood transfusion. So when speaking about transfusion, so this is an irreversible event that carries potential benefit to the patient because of course we are transfusing unit of the blood that might eventually increase the oxygen carrying capacity of the patient if you are transfusing the whole blood or the RBC products, or it could also correct for the problem related to your coagulation factors if you are transfusing a unit of the blood in the form of your plasma. But at the same time, this one will try to care also here potential risk for the patient, especially if you have here untoward reactions. So transfusion reaction, again, this is unfavorable reaction that try to happen to the patient after a unit of blood has been transfused to the patient. If left untreated or not able to manage immediately, that could eventually lead to the death of the patient. We can classify our transfusion reaction here as either immune hemolytic versus your non-hemolytic reaction. So when we speak about hemolytic reaction, so it involves here the RBC destruction. So if that one do not have an RBC destruction manifestation, the absence of your hemoglobinuria, hemoglobinemia, then that become your non-hemolytic. Then we have your immune versus your non-immune. Immune hemolytic reaction is due to your antigen antibody complex. Okay, so that might eventually have the recipient has an antibody directed towards the antigen presence on the donor cells which are incompatible with one another. Of course, the non-immune, so it does not involve here your antigen antibody reaction. Then we have here your immediate versus your delayed transfusion reaction. So when we speak about immediate, so the reaction, the manifestation, try to have or try to occur here within 24 hours of post-transfusion or after the patient has been given a unit of the blood. Whereas your delayed one that would try to have a manifestation here more than 24 hours, the patient is given a unit of the blood. So we have here the summary of our different transfusion reaction as to classification immune versus your non-immune. Again, for the immune, so these are transfusion reaction which involve your antigen antibody reaction. So classifying that one as your immediate. So when speak about immediate, that try to occur here within 24 hours of your blood transfusion. So this includes the following reaction. We have your immediate hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, your anaphylactic reaction, anaphylactoid reaction, allergic reaction, and we have your TRALI or transfusion-related acute lung injury. On the other hand, immune, which is your delayed, includes the following. We have your delayed hemolytic transfusion reaction, your alloimmunization, post-transfusion purpura, transfusion-treated graft versus host disease, and we have your immunosuppression. Your non-immune, on the other hand, which is your immediate, we have your bacterial contamination, transfusion-treated circulatory overload, physical or chemical damage to your blood products like exposure to your high temperature, and we have also your depletion and dilution of your coagulation factors and even your platelets. The delayed one, we have your iron overload and we have your air embolism. So we're going to discuss each of these different transfusion reaction. Okay, then we have here the transfusion reaction investigations. The first one we have here immediate lab investigation. So any untoward incident related to your blood transfusion should prompt here the laboratory in the blood bank section to investigate. Then we have additional testing, reporting transfusion reaction, and your laboratory workup. All that one will have here, some investigation as to whether the blood transfusion has been compatible really or there's a problem with the compatibility testing or not. Okay, we have here the steps in the administration of the unit of the blood, although we, the medtech, we are not the one transfusing a unit of the blood to our patient. So the first one, perform your clerical check. So this proper identification of the patient. You go to the ward if you have the request for the blood transfusion and you need to extract blood really for the intended recipient. That would be utilized your sample for the compatibility testing. Proper labeling of the blood tubes and proper blood issue. So that's why after performing your blood compatibility testing or cross-matching procedure, then whatever the unit of the blood that is compatible used during the testing should be the one labeled for the intended na recipient dapat. In bedside check, it's very important that in order for you to not misidentify the patient. Next one, we have here the warming of the blood here prior to the blood transfusion. So that's to prevent your hypothermia. You can perform that one by your running water or you can incubate at 137 degrees Celsius. Then for the blood transfusion, so again, we are not the one doing this blood transfusion. So we have first one, so the nurse would have here the blood set where to have here the filtering na naka-attach sa kanyang IV line ay may naka-attach dun sa ating blood bag that will try to filter the blood in order for that to prevent here the clotted component of the blood that will be transfused to the patient. So baka mag-clog ang pang-tubing natin na it would eventually not result here to the entire transfusion of the unit of the blood. You start with a slow infusion, that's 10 to 15, for the first 10 to 15 minutes, then make sure that one, you're able to finish the transfusion within 4 hours transfusion for the whole blood. But if you're transfusing a unit of the blood like your plasma, so usually that one is being transfused or consumed immediately. A matter of minutes lang siya, it would already consume. Okay, then we have here your monitoring the vital signs, very important too, that would provide you with the manifestation of reactions. First one, we have your fever, back pain, that will signifies on your immediate hemolytic transfusion reaction, pruritus, hives, okay, anaphylaxis that would be related to allergic reaction. Then we have also congestive heart failure related to your volume overload, and jaundice, red cell destruction, yellowish coloration of the patient, plus a decreasing concentration of the hemoglobin hematocrit every day compared to the previous day, signifying that you have a delayed transfusion reaction. So some incident here for the blood transfusion, you need to stop the blood transfusion. You can flush the IV line with your NSS or 0.5% albumin. Okay, that's the only approved the diluent natin to eventually flush off here to reduce the incident of your blood transfusion. For leading causes of your preventable lab error, improper specimen identification, improper patient identification, antibody identification error, and cross-match procedure error. That's would rely on the medtech on the laboratory. That's why we need to perform all the procedure correctly. Okay, then we have here the location of the preventable error here in the blood transfusion. So the first one would always be on the laboratory, followed here by the nursing service. So you could also have your anesthesia service and also your clinical staff. So laboratory always first here because of the major role of the laboratory in the blood transfusion, because we are the one collecting the blood. We are doing here the compatibility testing or the cross-matching procedure. So we discussed first here our hemolytic transfusion reaction. So again, hemolytic transfusion reaction would be characterized by the involvement of your RBC destruction. So based on that, we can have here your immediate characterized by the transfusion reaction occurring here less than 24 hours of post-transfusion. If that one occurring more than 24 hours, then it become a delayed hemolytic transfusion reaction, which involve always a red blood cell destruction. So first, we have your immediate hemolytic transfusion reaction. Again, it's trying to occur here approximately 1 to 2 hours. Okay, 1 to 2 hour period, most likely. The signs symptoms try to occur here even few minutes after the blood transfusion. So most likely, the reason for your immediate hemolytic transfusion reaction is with incompatibility with the recipient having an IgM antibody. So we're talking about the ABO blood group na incompatibility. So you could also have here your non-ABO antibody causing here your immediate hemolytic transfusion reaction, but it will be less severe compared with your ABO, which is your IgM. Okay, so your IgM mediated immediate hemolytic transfusion reaction would involve here the complement activation with your hemoglobinuria, hemoglobinemia with intra and your extravascular hemolysis. Okay, so you can have here your, again, like if the recipient has an ABO antibody responding to the donor's RBC antigen, it will form here immune complex. Okay, that will activate here the complement. And upon activation of the complement, it would result here to number 1. The patient tried to show here red cell destruction because of the activation of your membrane attack complex. And therefore, you got here your intravascular hemolysis, manifested with the hemoglobinuria, hemoglobinemia. Another one, it also tried to activate the vasoactive amines responsible here for the systemic effect and inflammatory actions like your vascular collapse and your renal failure. Another one, activation of our coagulation factors, our clotting factors, result here to your DIC, and that would have a bleeding manifestation because of that. Okay, we have here the manifestation of our immediate hemolytic transfusion reaction. So 35% of the patient try to develop here fever with or without chills. 34% with the oliguria or the absence of the urine output with a complete recovery. 13% develop here anuria or the oliguria is decreased urine output. Anuria would have here the absence of the urine output. And 10% die with sustained hypotension because of course, the inflammatory action, and eventually you have your clotting process. And 8% will have here your clotting coagulopathy. We have here therapy and prevention. So, if this immediate hemolytic transfusion action try to occur, number 1, you need to stop the infusion. Okay, then try to keep the IV line open. Try to wash with a saline solution. Then you can also give here mannitol to induce diuresis or urination of the patient. Alternative for mannitol, you can give ethacrylic acid, furosemide. Then for the hypotension, you can give the IV fluid or vasoactive drugs. And for the bleeding manifestation, for the coagulopathy, then you can give your fresh frozen plasma and could also have your cryoprecipitate. Bedside procedure. Number 1, stop the infusion. Keep the IV line open. Notify the physician. Perform the bedside check and try to return here the unit of the blood or any solution that's being incorporated the unit of the blood to your blood bank for investigation. Okay, now we have here your delayed hemolytic transfusion reaction. Again, delayed hemolytic transfusion reaction involve here the reaction occurring more than 24 hours with the RBC destruction. The RBC destruction, however, here is only extravascular or not within your blood vessel. And it would appear to be milder compared with our immediate hemolytic transfusion reaction. So there are two mechanisms here for the development of your delayed hemolytic transfusion reaction. One would be the secondary or anamnestic response, meaning to say the patient has been exposed in the blood group antigen previously, wherein the patient is negative for that by the pregnancy or even the blood transfusion, which allows the patient to be exposed, and then the patient tries to develop an antibody. And those antibody are IgG antibodies. Okay, or the primary alloimmunization, first time the patient maka-expose. But apparently, after more than 24 hours, the patient tried to develop an antibody. And once the patient tried to develop antibody more than 24 hours, that's the only time that try to lyse the transfused unit of the blood and even the patient, the recipient unit of the blood, and try to cause your delayed hemolytic transfusion reaction. And then again, we diagnose hemolytic transfusion reaction because of the decreasing concentration of the hemoglobin hematocrit of the patient every day post-transfusion. Mean to say there's a continued red cell destruction even after your blood transfusion procedure. Okay, we have here the offending antibody, which are your IgG antibody, causing here our delayed transfusion reaction, your RH, your KID, your DAFI, and your KEL blood group system. But so what we have discussed in other blood group system, majority of your 75% of our delayed transfusion reaction related to your KID antibody. Okay, we have your preventive transfusion reaction measures. Number 1, when we are storing the blood unit here, you need to store that one on their appropriate refrigeration temperature or the storage temperature. Never warm the RBC more than 37 degrees Celsius because it would have external damage to our RBC. Do not transfuse blood if the patient or the donor's identity is not accurate. And there are so many others also na mga measures listed in your PowerPoint. Kindly refer to that na lang. Okay, the next one we have here non-hemolytic transfusion reaction. So The non-hemolytic transfusion reaction, again, it did not involve here the RBC destruction, so there's no intra and extravascular hemolysis. This includes here your febrile hemolytic, non-febrile hemolytic transfusion reaction, and we have also your allergic reaction. So first one, we have here your febrile non-hemolytic transfusion reaction. So the American Association of the Blood Bank defined your febrile non-hemolytic transfusion reaction as 1 degree Celsius increase in the body temperature of the patient post-transfusion compared to the baseline temperature with no other causes. Okay, there are two physiology here why you have developed here your febrile hemolytic transfusion reaction. Number one, the recipient has anti-leukocyte antibody or anti-HLA antibody directed towards the donor's blood containing here the specific na HLA or even the WBC that try to react on the recipient na plasma containing that antibody. The second one, why you have developed here febrile is because of the storage of the blood in a blood bank graft that would allow the leukocyte to release your biological response modifier. As what we have discussed, biological response modifier are your cytokines and even your complements. Again, that's being released by the leukocyte only when that one is being stored in the blood bank graft. And that's also a reason for your febrile non-hemolytic transfusion reaction. Okay, clinical presentation, the patient appeared to be having the fever with or without chills. We have also here pallor, but in severe reaction, we have cyanosis, tachycardia, and dyspnea or even cough. So for the prevention of your febrile non-hemolytic transfusion reaction related to your WBC, then you need to have your leukoreduce na unit ng blood. Allergic reaction can range here from your mild reactions like in the pruritus, hives, wheals or flares, or erythema, that's a redness, to your severe manifestation like your bronchoconstriction, like your wheeze, angioedema with your tongue swelling, gastrointestinal tract manifestation with the diarrhea, and could also have you develop your cardiovascular instability, cardiac arrhythmias, shock, hypotension, and shock. Okay, our allergic reaction could be in the form of our anaphylactic reaction. Anaphylactic reaction is due to the presence of your allergen in the donor's blood that try to react in the recipient's or in the mast cells at the base of it has been sensitized with the IgE. So once your allergen try to combine with your mast cells, so kung itong mast cells natin may IgE dito. Ay, sorry. Okay, this one is your recipient. The mast cells of this one contains the IgE. If your blood contains here your allergen, magko-combine siya dito. That will trigger the degranulation of your mast cells or your basophil, and that will release the histamine. And the histamine here will be the one responsible for the manifestation of your allergic reaction, like increasing the pulmonary vasoconstriction of the pulmonary blood vessels. So, hindi makahinga ang patient natin at result here to the death of the patient. Anaphylactoid reaction, on the other hand, is just a less severe form of anaphylactic reaction. So, this is your anaphylactic-like. Okay, this one is triggering here your muscles. Okay, so mean to say your muscles of the patient has been triggered to release here the histamine without your IgE. So, still have the allergen, the donor's blood, tapos ang patient natin, recipient, ang muscles nito. So, if you have your allergen, papasok dito, it will allow degranulation of the muscles, but that one do not involve the IgE. That become your anaphylactoid. Another cause here of your allergic reaction, the patient has anti-IgA antibody. The patient tried to develop here anti-IgA antibody because previously the patient is IgA deficient. But apparently because of the exposure that may be previous na blood transfusion or pregnancy, the patient tried to develop here anti-IgA. Then here's your donor's blood contains an IgA. It will combine with anti-IgA of the recipient, and that will be responsible here for the allergic reaction. Okay, for the treatment, or the prevention, so they are given Benadryl or diphenhydramine. So basically, this one that would prevent here the blood transfusion. But I think the usual practice is the patient before given a blood is automatic na binibigyan nila ng Benadryl or your diphenhydramine, Benadryl, or your diphenhydramine that will prevent allergic reaction. Okay, the next one, we have your TRALI or transfusion-related acute lung injury. So this is characterized by the pulmonary manifestation 6 hours. After the transfusion, the patient tried to manifest a lung manifestation of form pulmonary distress, and the patient in the absence of other medical condition related to your lung disease. Mean to say the patient do not have a lung injury or lung infection, and that only that nagkakaroon siya ng pulmonary distress only after your blood transfusion. So mean to say that manifestation related to your blood transfusion. And you call it one as your transfusion-related acute lung injury. Okay, there are two mechanisms here for the transfusion-related acute lung injury. Number one is your immune TRALI. Immune TRALI here is your one-hit event wherein the recipient has already anti-human leukocyte antibody and anti-human neutrophil antibody. At ang donor's blood has an antigen, human leukocyte antigen, and human neutrophil antigen. So therefore, upon transfusion, you're able to form antigen-antibody complex that results to aggregation in the pulmonary circulation and mahirapan ang patient natin huminga that results to your pulmonary distress that become your TRALI. Your non-immune TRALI, on the other hand, is a two-hit event. The first event is characterized here by the presence of a lung disease that try to prime the neutrophil of the recipient. So once you try to transfuse the blood, that's the neutrophil. Since the neutrophil of the recipient has already been primed, it will allow the reaction with the donor's blood containing the neutrophil. And that's what results here to your reactions resulting to your damage in your endothelium, pulmonary capillary permeability increase, and eventually resulting to your non-cardiogenic pulmonary edema. Okay, the next one, we have your TACO. TACO here, transfusion-associated circulatory overload, characterized here as a complication of your massive blood transfusion that results here to your congestive heart failure, plus your pulmonary distress and your hypoxemia because of, again, too much blood administration. So we have here the parameter or the test that would help us to diagnose your TACO or transfusion-associated circulatory overload. Okay, we have your brain natriuretic peptide. The ratio here post-transfusion versus your pre-transfusion of 1.5 or a concentration after transfusion of 100 picogram per ml signifies your transfusion-associated circulatory overload. Okay, then we have your TAS, transfusion-associated sepsis. So this is primarily by contamination of the unit of the blood with your bacteria. So the most prone here to our bacterial contamination, the unit of the blood will always be your platelet concentrate. Is because here we try to store the platelet concentrate in the room temperature. So we have here, we define that transfusion-associated sepsis here as the 2 degrees Celsius increase in the temperature of the patient post-transfusion compared with the baseline temperature before the transfusion. We have here the most common contaminant with the bacterial infection here for the unit of the blood. So gram-positive, you have staph, your strep, and bacillus species. For the gram-negative, you can have your serratia, your Yersinia, Acinetobacter, Escherichia, and we have also your Providencia. Okay, to diagnose here, to identify specifically if the unit of the blood or even the patient has transfusion-associated sepsis, you just need to extract blood for both the patient and of course the unit of the blood and try to perform your blood culture. So you should, the two here in a specimen mo with the patient blood and the blood coming from the blood bank should coincide with one another in terms of the bacterial isolated. Okay, then we have your PTP, post-transfusion purpura. So this is characterized here by redness, okay, of the skin because of the transfusion of the unit of the blood which is incompatible with the donor and the recipient. Basically, the recipient contains your anti-platelet antibody which try to destroy the platelets of the transfused unit of blood. Okay, and that results here to your thrombocytopenia occurring 1 to 24 days after the transfusion. And lastly, we have your iron overload. This is also the complication of your massive blood transfusion, characterized here by multi-organ failure because of the excessive iron coming from the too much unit of blood being given to the patient. And this excess iron try to accumulate here in the vital organs like your liver, your heart, endocrine gland that results here to the organ failure. So each unit of the blood contains 250 milligrams of the iron. So remember that if you're giving like 4 units, 5 units, 10 units ng blood, that might result here to the complication iron overload. Okay, then removal of this one, so with the use of our chelating agent. So you can have here your deferoxamine, deferoprone, and we have also your oral deferoxerox. Okay, so we consider your iron overload as non-immune, and this one is also a delayed type of your transfusion reaction. Okay, so that's it with our transfusion reaction. Okay, thank you.